Chapter 23, The Child with Cardiovascular Dysfunction. Congenital heart disease happens in about 5 to 8 per 1,000 live births. 2 or 3 of these infants are symptomatic in the first year of life. Congenital heart disease is the major cause of death in the first year of life after prematurity. Most common anomaly is a ventricular septal defect. In 28% of kids with congenital heart disease, another recognized anomaly is usually present. There are 2 types of cardiac defects. Congenital heart disease includes primarily anatomic abnormalities present at birth that result in abnormal cardiac function. The clinical consequences of congenital heart defects fall into 2 broad categories: heart failure and hypoxemia. Acquired cardiac disorders are disease processes or abnormalities that occur after birth and can be seen in the normal heart or in the presence of a congenital heart defect. When a newborn takes the first breath, the fetal vascular system undergoes abrupt changes. The umbilical vein and umbilical arteries. Before birth, this umbilical vein delivers oxygen and nutrients to the fetus. The foramen ovale closes as pressure in the left atrium exceeds the pressure in the right atrium, and the ductus arteriosus starts to close in the presence of increased oxygen. This is in your book, and you can review it at your leisure within the book, but it just talks about how the heart changes from pre-birth to after birth. So the indicators of cardiac dysfunction, they usually appear 4 to 12 weeks after birth. They may be seen as a failure to thrive, poor weight gain, activity intolerance. They may show developmental delays. They may have a positive prenatal history and a positive family history of cardiac disease. Major categories to investigate in the cardiac history are poor weight gain, poor feeding habits, and fatigue during feeding, frequent respiratory tract infections and difficulties, and evidence of exercise intolerance. You may see the cyanosis during feedings or exercise intolerance. The parents are not going to see a murmur or the sternal shift per much, and they're not going to see the crackles. Diaphoresis, I believe, would happen later. So just be aware. And then, of course, the hepatomegaly is the enlarged liver because of the inability of the heart to adequately pump blood forward. A useful classification system is based on hemodynamic characteristics. These blood flow patterns are 1. Increased pulmonary blood flow, 2. Decreased pulmonary blood flow, 3. Obstruction to blood flow out of the heart, or 4. A mixed blood flow, in which saturated and desaturated blood mix within the heart or the great arteries. Increased pulmonary blood flow. In this group, the cardiac defects, intracardiac communications along the septum, or an abnormal connection between the great arteries allows blood to flow from the higher pressure left side of the heart to the lower pressure right side of the heart. Clinically, patients demonstrate signs and symptoms of heart failure. ASD and VSD and patient ductus arteriosus are typical anomalies in this group. That would be atrial septal defect and ventricular septal defect. Mixed blood flow. Clinically, these patients have a variable picture that combines some degree of desaturation, although cyanosis is not always visible, and signs of heart failure. Some defects, such as transposition of the great arteries, cause severe cyanosis in the first days of life and later cause heart failure. Others, such as truncus arteriosus, cause severe heart failure in the first weeks of life and mild desaturation. This is just a picture of your atrial septal defect. Here is a picture of the ventricle septal defect. And here is a picture of your atrioventricular canal defect, patent ductus arteriosum, So obstructive defects are those in which blood exiting the heart meets an area of anatomic narrowing or stenosis, causing obstruction to blood flow. The presence in the ventricle and in the great artery before the obstruction is increased, and the presence in this area beyond the obstruction is decreased. Coarctation of the aorta, which is a narrowing of the aortic arch, aortic stenosis, and pulmonic stenosis are typical defects in this group. Clinically, infants and children exhibit signs of heart failure. Children with mild obstruction may be asymptomatic. Rarely, as in severe pulmonic stenosis, hypoxemia may be seen. In this group, the defects, there is obstruction of the pulmonary blood flow and an anatomic defect, as in arterial septal defect or ventricular septal defect, between the right and the left sides of the heart. This is just a picture of your coarctation of the aorta, and here is aortic stenosis, pulmonic stenosis. Decreased pulmonary blood flow. In this group of defects, there is obstruction of pulmonary blood flow and an anatomic defect, such as atrial septal defect or ventricular septal defect, between the right and left sides of the heart. Because blood has difficulty exiting the right side of the heart via the pulmonary artery, pressure on the right side increases, exceeding left side pressure. This allows desaturated blood to shunt right to left, causing desaturation in the left side of the heart and in the systemic circulation. Clinically, these patients have hypoxemia and usually appear cyanotic. Tetralogy of Fallot and tricuspid atresia are the most common defects in this group. And here is an example of the tetralogy of Fallot, and here is your tricuspid atresia. Your mixed defects. Clinically, these patients have a variable picture that combines some degree of desaturation, but cyanosis is not always visible, and signs of heart failure. Some defects, such as transposition of the great arteries, cause severe cyanosis in the first days of life and later cause heart failure. Others, such as truncus arteriosus, cause severe heart failure in the first weeks of life and mild desaturation. And here is a picture of the transposition of the great arteries or transposition of the great vessels. And here is the total anomalous pulmonary venous connection. Here is a hypoplastic left-sided heart syndrome. You can see the size of the left ventricle there is, well, left atrial too. So CHF in children. Heart failure most frequently occurs secondary to a structural abnormality, such as septal defects, that results in increased blood volume and pressure within the heart. It can also result from a myocardial failure in which the contractility or relaxation of the ventricle is impaired. This can occur with cardiomyopathy, dysrhythmias, or severe electrolyte disturbances. Heart failure can also occur because of excessive demands on a normal heart muscle, such as sepsis or severe anemia. Heart failure is often separated into the two categories, right-sided and left-sided heart failure. Right-sided failure, the right ventricle is unable to pump blood effectively into the pulmonary artery, resulting in increased pressure in the right atrium and systemic venous circulation. Systemic venous hypertension causes hepatosplenomegaly and occasionally edema. In left-sided failure, the left ventricle is unable to pump blood into the systemic circulation, resulting in increased pressure in the left atrium and pulmonary veins. The lungs become congested with blood, causing elevated pulmonary pressures and pulmonary edema. The signs and symptoms of heart failure can be divided into three groups: impaired myocardial function, pulmonary congestion, and systemic venous congestion. The goals in the treatment of heart failure are 1. To improve cardiac function by increasing contractility and decreasing afterload. 2. Remove accumulated fluid and sodium by decreasing preload. And 3. Decrease cardiac demands. 4. Improve tissue oxygenation and decrease oxygen consumption. And that also means decreasing the workload of the heart. The nursing measures in the care of a child with heart failure are to assist in improving cardiac function, decrease cardiac demands, reduce respiratory distress, and maintain nutritional status, promote fluid loss, and provide family support. Hypoxemia. There's two physiologic changes that occur in the body in response to chronic hypoxemia: polycythemia and clubbing. Polycythemia, an increased number of red blood cells, increase the oxygen carrying capacity of the blood. Clubbing, a thickening and flattening of the tips of the fingers and toes, is thought to occur because of chronic tissue hypoxemia and polycythemia. Infants with mild hypoxemia may be asymptomatic except for cyanosis and exhibit near normal growth and development. Hypercyanotic spells, also referred to as blue spells or tet spells, because they are often seen in infants with tetralogy of Fallot, may occur in any child whose heart defect includes obstruction of pulmonary blood flow and communication between the ventricles. Hypercyanotic spells occur suddenly, and prompt recognition and treatment are essential. Persistent cyanosis as a result of cyanotic heart defects places the child at risk for significant neurologic complications. Cerebrovascular accident, brain abscesses, and developmental delays, especially in motor and cognitive development, may result from chronic hypoxia. To distinguish between the cardiac and pulmonic hypoxia in a hyperoxia test is helpful. The infant is placed in a 100% oxygen environment, and blood parameters are monitored. A PaO2 of 100 millimeters of mercury or higher suggests lung disease, and a PaO2 lower than 100 suggests cardiac disease. The use of prostaglandins have been life-saving for infants with ductus-dependent cardiac defects. The increase in oxygenation allows the infants to be stabilized and have a complete diagnostic evaluation performed before further treatment is needed. Blue lips and fingernails are obvious signs of their hidden cardiac defect. Clubbing and small, thin stature in older children further indicates severe heart disease. Adolescents are especially concerned about their body image. Children with cyanosis are often teased about their appearance and singled out as different. Dehydration must be prevented in children with hypoxemia because of the potentiates the risk of CVAs. Fluid status is carefully monitored with accurate intake and output and daily weight measurements. I'd like you to, as I read this again, consider why a child with hypoxemia why that hypoxemia could lead to an increased risk of CVAs with dehydration. Any compromise in pulmonary function will increase the infant's hypoxemia. Good hand washing and protection from individuals with an obvious respiratory tract infection are important. Aggressive pulmonary hygiene, treatment with antibiotics and antiviral agents are indicated, and supplemental oxygen to decrease hypoxemia are necessary measures. Cardiac catheterization procedures can be divided into three categories. 1. Diagnostic procedure, including angiography, that measure pressures and saturations to establish cardiac diagnosis. 2. Interventional procedures, in which the catheters or balloon devices are used to correct cardiac defects. And 3. Electrophysiology studies, in which catheters with electrodes are used to evaluate dysrhythmias. Diagnostic cardiac catheterization provides important information about oxygen saturation of blood within the chambers and great vessels, pressure changes, changes in cardiac output or stroke volume, and anatomic abnormalities. Pre-procedural care includes preparing the child and the family for the procedure. And remember, this is directly related to their developmental stage. Use developmentally appropriate materials to explain the procedure to the child. Assess and mark pulses. Baseline O2 saturation needs to be monitored and recorded, and they must remain NPO or nothing by mouth prior to the procedure. Following the procedure, check the pulse distal to the site. Monitor the temperature and color of extremities. Take vital signs every 15 minutes. Monitor the blood pressure. Monitor the dressing for bleeding or hematoma. monitor intake and output, and monitor blood glucose levels. Acquired cardiovascular disorders, infectious and inflammatory cardiac disorders. Bacterial or infective endocarditis is an infection of the valves and inner lining of the heart. Prevention of infective endocarditis in certain children with congenital heart disease involves administration of prophylactic antibiotics when specific procedures are performed. Definitive diagnosis rests on growth and identification of the causative agent in the blood. At least 3 blood cultures are drawn at different times to aid in the diagnosis. Vegetations on the valve and abnormal valve function can often be visualized by echocardiography. A diagnosis of culture-negative infective endocarditis is made when the patient has echocardiographic or clinical evidence of infective endocarditis, but no organism can be cultured. Several laboratory findings may suggest infective endocarditis, including anemia, elevated erythrocyte sedimentation rate, leukocytosis, and microscopic hematuria. Treatment should be instituted immediately and consists of administration of high doses of appropriate antibiotics IV for 2 to 8 weeks. Nurses counsel patients and parents of high-risk children concerning the signs and symptoms of endocarditis and the need for prophylactic antibiotic therapy before dental work. In many cases, IV antibiotics may be administered at home with nursing supervision. Nursing goals during this period are 1. Preparation of the child for IV infusion, usually with an intermittent infusion device and several venipunctures for blood cultures. 2. Observation for side effects of antibiotics, especially inflammation along the venipuncture site. 3. Observation for complications, including embolism and heart failure. And 4. Education regarding the importance of follow-up visits for cardiac evaluation, echocardiographic monitoring, and blood cultures. Rheumatic fever is a systemic inflammatory disease that occurs after infection with group A hemolytic streptococci pharyngitis. Acute rheumatic fever can damage the cardiac valves and is associated with previous group A streptococcal infection. Acute rheumatic fever is the result of an abnormal immune response to the group A strep infection, usually pharyngitis, in a genetically susceptible host. It occurs most often in late school-age children and adolescents and is rare in adults. Acute rheumatic fever is a self-limited illness that involves the joints, skin, brain, and heart, but cardiac valve damage, which is referred to as rheumatic heart disease. The most significant complication of acute rheumatic fever occurs in more than 1/2 of the cases. The mitral valve is the most often affected. Strong evidence supports a relationship between the upper respiratory tract infection with group A strep and subsequent development of acute rheumatic fever, usually within 2 to 6 weeks. Prevention or treatment of group A strep infection prevents, I'm going to go back and just start that whole paragraph over. Strong evidence supports a relationship between upper respiratory tract infection with group A strep and subsequent development of acute rheumatic fever within 2 to 6 weeks. Prevention or treatment of group A strep infection prevents acute rheumatic fever. If the group A strep infection is untreated, antibodies are produced to fight the infection, which can also act against the heart valves, causing damage. If children have one strep infection, they are at greater risk for repeated infections, and recurrent infections cause the cumulative valve damage in rheumatoid heart disease. No, rheumatic heart disease. I'll get it straight. The updated Jones criteria suggests that the presence of 2 major manifestations or 1 major and 2 minor manifestations with supportive evidence of recent group A strep infection indicates a high probability of acute rheumatic fever. You can please refer to page 767 of Nursing care guidelines and be familiar with those. The most reliable and best standardized test is an elevated or rising anti-streptolysin titer, which occurs in 80% of children with acute rheumatic fever. Prophylactic treatment against recurrence of acute rheumatic fever or a secondary prevention is started after the acute therapy. The treatment of choice is intramuscular injections of benzathine penicillin G every 28 days because it is the most effective. Alternative therapy includes oral doses of penicillin or erythromycin twice a day or one daily dose of sulfadiazine. The duration of secondary prophylaxis is based on the presence of residual heart disease. In acute rheumatic fever occurs without carditis, prophylaxis is recommended for 5 years or until the age of 21, whichever is longer. In patients with carditis, 10 years is recommended or until 21 years old. In patients with rheumatoid heart disease, rheumatic heart disease, prophylaxis can continue until the age of 40 years or may be indicated indefinitely depending on the individual's risks. Kawasaki disease, mucocutaneous lymph node syndrome, is an extensive inflammation of small vessels and capillaries that may progress to involve the coronary arteries, causing aneurysm formation. The administration of IV immunoglobulin is an important aspect of treatment. The 3 phases include the acute phase, which is a sudden high fever, unresponsive to antipyretics and antibiotics. Subacute phase, it lasts from the end of fever through the end of all Kawasaki disease clinical signs. And then the convalescent phase is clinical signs have resolved, but laboratory values have not returned to normal. This usually ends when normal values have returned at 6 to 8 weeks. The treatment of Kawasaki's disease is acetylsalicylic acid or aspirin, 80 to 100 milligrams per kilogram per day for fever, IV immunoglobulin, and then 3 to 5 milligrams per kilogram a day of an antiplatelet drug. Hyperlipidemia. Hypercholesteremia refers to excessive cholesterol in the blood. Dyslipidemia is a term used to describe all abnormalities in lipid metabolism, including low levels of high-density lipoprotein or good cholesterol and high-low-density lipoprotein or lousy cholesterol for high triglycerides. Please refer to page 769, table 23.5 for classification of cholesterol levels in children. Contrast to prior guidelines, the National Heart, Lung, and Blood Institute guidelines now recommend universal screening for all children between the ages of 9 to 11 and again between the ages of 17 to 21. In addition, selective lipid screening continues to be recommended for children over 2 years old who have a family history of dyslipidemia or early heart disease in a first or second degree relative, as well as for those children who have individual coronary risk factors. The first step in the treatment of high cholesterol is focused on lifestyle modification. The National Heart, Lung, and Blood Institute guidelines advocate the benefits of a heart-healthy diet for all children. In addition, children with known elevated cholesterol should have individual nutritional counseling, ideally by a dietitian with expertise in pediatric lipids. The most recent guidelines for lipid abnormalities in children recommend treatment with statins if pharmacologic therapy is indicated after lifestyle modification has been attempted. Another class of lipid-lowering drugs includes the bile acid-binding resins. Bile acid-binding resins act by binding bile acids to the intestinal lumen. Because the intestine does not absorb them, resin binders do not produce systemic toxicity and are safe for children. Cholestyramine or Questran and Cholestipol are both powders that are mixed with water or juice just before ingestion. Hypertension is defined as the consistent elevation of blood pressure beyond values considered to be the upper limits of normal. The 2 major categories are essential hypertension or hypertension with no identifiable cause and secondary hypertension, which is subsequent to an identifiable cause. Education of the child with hypertension and the family focus on drug therapy, diet control, and appropriate exercise. Most instances of hypertension in young children occur secondary to a structural abnormality or an underlying pathologic process. Although this is being challenged by screening programs of relatively healthy children, the most common cause of secondary hypertension is renal disease, followed by cardiovascular, endocrine, and some neurologic disorders. Children and adolescents with consistently elevated blood pressure readings from no known cause or those with secondary hypertension not amenable to surgical correction may be treated with a combination of lifestyle and pharmacologic interventions. Dietary practices and lifestyle changes are important in the control of hypertension, both for the children as well as adults. Heart transplantation has been extended to infants and children with cardiomyopathy and complex congenital heart defects involving ventricular dysfunction, such as hypoplastic left heart syndrome. Orthotopic heart transplantation refers to removing the recipient's own heart and implanting a new heart from a donor who has had brain death but a healthy heart. Heterotropic heart transplant refers to leaving the recipient's own heart in place and implanting a new heart to act as an additional pump, or piggyback heart. This type of transplant is rarely done in children. Parents and older adolescents need extensive education about the risks and the benefits of transplantation so that they can make an informed decision. Patients are listed on a national computer network organized by the United Network of Organ Sharing to match donors and recipients. The leading cause of death in the first 3 years after heart transplantation is rejection, with the greatest risk in the first 6 months. The heart transplant recipient must be carefully monitored for signs of rejection, infection, and side effects of immunosuppressant medications. The patient and the family's psychosocial well-being also needs to be assessed to identify issues such as increased family stress, depression, substance abuse, and school problems. Non-compliance and intense medication regimen, especially during adolescence, can lead to serious medical problems and can be fatal. Among the 3,098 children listed for a heart transplant between 1999 and 2006, the median age was 2 years. 60% of the patients were listed as the top status, 30% were ventilated, and 18 on supportive measures. And of those children, 17% died. 63% received transplants, 8% recovered, and 12% remain listed. These numbers concluded that U.S. waiting time remains high in the current era, and high-risk groups in these categories could benefit from emerging cardiac assist devices, such as extracorporeal membrane oxygenation and ventricular assist devices. Anaphylaxis is the acute clinical syndrome resulting from an interaction of an allergen and a patient who is hypersensitive to that allergen. Persons at risk for anaphylaxis may be identified by a history of previous allergic reaction, history of atopy, history of severe reactions in family members, and positive skin test to an allergen. Moderate or severe distress presents a potentially life-threatening emergency. Establishing an airway is the first concern, as with all shock states. Epinephrine is given subcutaneously or IV as an antihistamine, and to support the cardiovascular system and increase blood pressure. Other routes for giving epinephrine are intramuscular and via the airway, either nebulized or injected through the endotracheal tube. In severe anaphylaxis, epinephrine by any route is better than none. Fluids are given to restore blood volume. Additional vasopressors may be given to improve cardiac output. Shock or circulatory failure is a complex clinical syndrome characterized by inadequate tissue perfusion to meet the metabolic demands of the body, resulting in cellular dysfunction and eventual organ failure. Emergency treatment for shock includes ensuring ventilation, administering vasopressors, fluids, blood, and antibiotics as needed, and providing supportive measures such as correct positioning, warmth, and psychological reassurance for the child and the family. Toxic shock syndrome is a relatively rare condition caused by the toxins produced by the Staphylococcus bacteria. Nursing management of the patient with toxic shock syndrome focuses on prevention, primarily through education concerning safe tampon use. Toxic shock syndrome became well known in the 1980s because of the striking relationship between the disease and tampon use. An aggressive health education campaign about the dangers of prolonged tampon use and a change in the chemical composition of tampons have markedly reduced the incidence of toxic shock syndrome in menstruating women. Cases of toxic shock syndrome have also been reported in men, older women, and children. A history of tampon use contributes to the diagnosis. Additional laboratory tests include cultures from blood, the vagina, the cervix, and any discharge. I'm still very confused about reported in men. Other laboratory tests are those that facilitate the management of shock. Adolescent girls who use tampons can be taught general hygiene measures such as good hand washing and careful insertion to avoid vaginal abrasion. It is wise to modify their use, alternating with sanitary napkins, perhaps using the napkins during the night when at home, during the day, and when flow is light. Young girls are advised not to use super absorbent tampons and not to leave any tampon in the body for more than 4 to 6 hours.